everybody. This is so odd to always talking to this weird, strange looking alien camera. So I'll look at all of you. Glad you're all here. Thank you for coming. We are a D2 Counseling puts these free lecture series on, and we've been doing that for several years now. And we do it in conjunction with the Unity Church, which is where we are. We invite all of you online if you would like to come live. We now are doing hybrid sessions, I think many of you know. So we'd love to see you in person. Thank you all for being here. And thank you, Unity, for helping us, give us space to do this. D2 Counseling is a group of therapists that have come together. We're all very systems oriented, which means that we work with individuals from a family perspective, from a community perspective, that the individual grows more quickly if we can help them change the system that they're living in. So we all work from that philosophical and theoretical approach. And we have a group of clinicians that work from age 3 to 93. We have some fabulous senior citizens that are just amazing to work with. And we work with kids too, and everything in between. We do groups. We run about 10 groups a week, which we're very proud of. I'm very proud of, because in this time of the pandemic, we've really feel like we're offering a service for people to connect when we've all felt very disconnected. And then we do intensives and workshops. We do a lot of couples work. We do a lot of family of origin work. We have trauma specialists, EMDR specialists, and like I said, couples, families, children, adolescents. So if you need a resource, feel free to call us. We're very happy to help you find a place that will fit your needs if it's not with us. Tonight we have a wonderful speaker who I'm so excited to hear, because I have not heard him speak, but I've talked to you on the phone and we had a wonderful conversation. I also mentioned his name this morning with some clients, and several of them went on and on about how terrific he is. So welcome, and so glad to have you, Dr. Dixon.
Alrighty, y'all. So I'm going to stand here. It's good to see everybody online. Good to see everybody in the room. So I'm Dr. Brian Dixon. I think I can just click on the other thing, right?
You're looking at me.
Yeah, it's a hearing. So I can just click this to get here, right?
But we need to share it so that they
Oh, okay. So we're going to work and get this screen all shared, everybody. So a little bit about me. So my name is Brian Dixon. I am a child, adolescent, and adult psychiatrist. I did a combined program. So it's a combination of pediatrics, adult psychiatry, and child psychiatry. And I'm from Texas, and born and raised in Texas, yeah, East Texas. And
Where
so,
are these things?
yeah, Lufkin.
Okay, I'm from, I was still Methodist.
Oh yeah, yep, back in nowhere. Yep, I knew exactly where that is. So, and so yeah, so pleasure to be here. So my background, East Texas, went from there to Baylor for undergrad, to Texas A&M for med school, University of Kentucky for training, then came back to Texas, worked at a federally qualified health center for a year, and then I came over to Cook Children's in Fort Worth, did that for a couple of years, and then started my private practice. And so it's a direct pay practice, so I don't take any insurance and that sort of thing, which is a whole other discussion that we'll have someday. But I've worked at Parkland and Baylor Scott and White, MHMR over in Tarrant County. So I have a pretty decent idea of all the different systems of care. So and so yeah, so it's a pleasure to be with y'all this evening. And so we're going to jump into this discussion. Are we good?
Yes, you just need to click share screen.
Okay, so yeah, perfect. Yeah, so we'll go ahead and share the screen, and hopefully y'all can still hear my wonderful voice. And so for what it's worth, so I drove over from Fort Worth, and I love coming over this way because I actually come every Tuesday to go to choir practice. So I'm bumping choir practice so that I can be here with y'all. So yay! So yeah. And so yeah, so one of the reasons why I love to give this talk is because in the mental health world, we are all interdisciplinary. So I think there's a lot of misunderstanding for folks outside the system sometimes of how psychiatrists and therapists and counselors and psychologists all work together. And so I said, I want to put together this presentation because we truly, truly do work together, at least the good ones. So, and I think D2 is a wonderful organization. And I try to be very complimentary and integrative with them. And so by the end of this session, hopefully we will answer the age-old question, is there a pill for this? Okay, so that's my goal if everything works correctly. And so we'll start off our first slide. Hopefully this works. No, wait, let me go backwards. I can already tell you I'm gonna have to be very, very, very sensitive. So I always give the disclaimer that I am a therapist, I'm a psychiatrist, but I am not your therapist or your psychiatrist. So if there's something going on, if you have questions about something, and you're like, oh my gosh, this is pertaining to me, talk to your person. So if you are in counseling or in psych treatment, talk to your person there. If you are a fellow colleague, hopefully if I get something wrong, you'll email me very nicely because I have feelings too. And so, and actually I'm putting this over here and I'm gonna do the left-handed version. So hopefully this all works okay. I tried to put this in Prezi because it's a really fun little thing, which is slightly different than PowerPoint. So, and you know what? I may actually just do this. Ha ha ha. All righty, perfect. So what we're gonna do, anytime I'm working, so I work with itty bitty. So my youngest is 3 and some change, and then my oldest is 73. And so anytime I'm putting together a treatment plan, so I'm a full believer in the integrated model. And so anytime I'm putting together a treatment plan for anybody, it always includes basically 3 different parts. And so you'll see up on the screen, the way that I break it down is behavior modification. So I'm gonna walk y'all through that. The therapy component, and I'm going to walk you through that, and then the medicine component. And the key for every good treatment plan is you have to have all 3 parts. It's just the different levels for each one. Yeah, absolutely. And so disclaimer again, for all of my therapist friends, when I say behavior modification, it's behavior therapy, but it looks better as behavior modification. So just go with it, yeah, if y'all will. And so, I always tell my parents and my patients and everybody that the medicines are the absolute last things that we're going to talk about, because there's so many other things that we can do first that are non-medical related. And like I said, we'll answer if there is a pill for this by the end of the session. So behavior modification. So the way that I explain it, what it is and what it does is, what am I doing to make my situation worse? And then what can I do to make my situation better? Okay, there's an infinite number of these things. And when I say infinite, I mean, you could truly go on and on and on. And so for me, because I have only a set amount of time, especially in that first appointment, that I'm working with a family or I'm working with a person or a patient, I whittle it down to 4 different areas. And these are the 4 that I always hit. The first being diet. And so you are what you eat, y'all, that is actually legitimately true.
That's so sweet. Okay.
Yeah. And so when it comes to diet, again, there's a plethora of things that you can do for a diet to improve a diet, but I really, really honed down on just a couple. So number 1, please increase your protein. We don't get enough quality protein. So proteins, especially from like fishes and chickens, and a lot of the meats, and then and vegetables, so legumes and beans and that sort of thing, so that you're getting good quality protein, because those proteins are the things that you use to make your neurotransmitters, to make the things that I'm going to address later on in the discussion. And so if you're not eating a good diet, we're already starting behind the 8 ball, if you will. The next thing, decrease your carbohydrates. So carbohydrates are anything that's sweet and delicious. They come in lots of different versions. So like fructose is a carbohydrate, but fructose is in fruit. Generally, you can't really overdo those things. If you eat too much fructose, you'll just poop it all out. So if you want to eat as many apples or oranges or that sort of thing, go to town. It's those other carbohydrates, the glucose carbohydrates, so pastas and rice and chips and cookies and those sorts of things can cause all sorts of havoc. And I never advocate for taking it completely out of your diet. I say just decrease the amount that you're eating. And the research is suggesting over the last 30 to 40 years, our portion size as Americans has increased by 50%. So whatever you're eating, your body only needs half of it. So you can automatically just take half and take that off your plate as for what your portion is. And so if you increase your protein, you decrease your carbohydrates, and then you eat increased fiber, because pooping is important. People underestimate the power of pooping and the importance on your mood, because there's that whole gut mind and connection and interaction, and fiber is really good at helping clean things out, right? And so I always harp on diet first. Strangely enough, in medical school, they don't actually teach us anything about nutrition, which is kind of creepy and weird. And so what I've had to learn is either through practice myself or having great nutritionists that I work with, as well as just kind of making stuff up as we go along, right? And so, so to reorient you, behavior modification, the first third of our treatment plan, the first thing that we talk about is your diet. And if you follow those 3 rules, and I coach on those 3 rules, those are generally a great place to start. Next up is sleep. So we spend a third of our lives asleep, and because we are an overachieving, ridiculous society, we don't sleep enough. And so I am not a sleep expert. I play one on TV. And so generally, most times I give people just the basics of kind of just good sleep hygiene. And the key with sleep is you set the same sleep and wake times every single day. So try not to move. I know we just went through one, right, with daylight savings time. So that kind of messes everything up. And if you'll notice, there's actually research that says that during daylight savings, starting and ending, people have a much more difficult time functioning. And that's because we are creatures of habit. Human beings are creatures of habit. So we need sleep. So try to set the same sleep and wake time every day. And then, and I said, every single day for emphasis, because we tend to say, oh, I'll just make up for it. And as I understand sleep, you don't actually catch up. Once it's gone, and you don't get it back. And so be very thoughtful each day that you try to go to bed at the same time and then wake up at the same time. And then sleep hygiene is a plethora of things. Again, I'm sure y'all could have a whole lecture series just about sleep, but the big ones are try not to have your phone in your room, and then TV. So phone and TVs are the 2, TVs for kids, phones for teenagers, phones for adults are kind of the big boogers. And I have to always remind my kids, because they'll go, oh, I go to sleep, and parents, I go to sleep with the TV on and it's soothing. And one of the hiccups with doing that is that even while you're asleep, your brain is still processing whatever it's hearing. So if it's hearing forensic files and gunshots and all this stuff, you're still hearing it even though you're asleep. And so I always encourage everybody to just turn the electronics off. And so we talked about when it comes to behavior modification, we started with the diet. So we talked about the importance of the diet. We talked about the importance of sleep. And again, I try to keep these as simple and as straightforward as possible. And whenever my patients come in, I used to handwrite these out, but now I have a little printed template that everybody gets, so that then when you're leaving the doctor's office, you have your printed plan. And so we talked about diet, we talked about sleep. Next up is exercise. So again, a million different things that you can do with exercise. I don't like to belabor the point. I say pick anything that you can do outside for 30 minutes. I don't care what it is. If it's walking, go walk. If it's HIIT training, it's HIIT training. If it's flying a kite, fly a kite. I do not care what you do as long as you do it outside, because we know the power of nature and biorhythms and sunlight. So if you're outside and the sun is on you, you're getting, especially for our folks, as long as you don't have agoraphobia, which is the fear of outside. Being outside, especially if you're an anxious person, helps open up your sense of the world, because generally anxiety pulls you in and makes you feel like you're trapped. And so, yeah, being outside, being around other folks, if you're in a place that you feel unfamiliar, make sure you wear your mask and all those things. So, I zoom in on this to emphasize 30 minutes. Ideally, it'd be great if you were sweating, like you're doing something to get your heart rate up to sweat a little bit. That would be ideal. But if you can't, that's fine. One of the fun things to do with this one is during your lunch break, go out and instead of sitting at your desk, scarfing down food, especially for my therapist friends, because you don't pee enough and you don't eat enough because y'all are going back to back to back to back to back. Taking that time during your lunch break to try to walk around and get more fresh air is super, super helpful. And so that we talked about diet, we talked about sleep, we talked about exercise, and then the last being triggers. And so a trigger for me, and again, this is totally your wheelhouse. So a trigger, the way that I describe it, is it's anything that you do without thinking about it. Those external things that make you react without thinking. So the biggest one, the most common one I can think of just right off the bat is when your phone buzzes. Your immediate instinct is to do what? Pick it up, right? And that is, it's a trigger for you. And we've been conditioned, so that's a fancy psychological term for you've been trained to pick it up. If something buzzes, you pick it up. If the phone rings, you pick it up and say hello. And so triggers are any number of things, especially if you're doing family systems work. One of my biggest triggers just in dealing with my own family is when you get that phone call from the person you don't want to talk to, and you pick it up and you go, and that feeling, that heaviness of, do I have to talk to this person? That's a trigger, right? And so mitigating that trigger, managing those triggers can be so helpful so that you don't feel the immediate effect of those things. And that's why you go to therapy. That's what therapists are really good at working with. And so you work on it. Go ahead. Oh, did you have a question? Oh, okay.
I was just thinking out loud.
Oh, okay, gotcha. And so to pan back out, so behavior modification being all the things related to your diet, all the things related to your sleep, all things related to exercise, and then those triggers. And again, I only chose 4. Your therapist will really personalize those things and help you identify other areas where you can improve. To me, behavior modification is the hardest part of the entire treatment plan. And if there was a pill for this stuff, I would totally give it to you and I'd make $1 million and I would go on vacation and not work so hard. But alas, that is not the case. And so instead, we work through each of these areas. And what I tend to do is when folks come in, I try to make sure to hold them accountable in a very nice way. Hey, how's your diet? How's your sleeping? What happens every time you get to class and someone says something to you? Because that's a trigger, right? Especially for my little kids who are screaming and yelling and throwing fits. What types of things are you eating? That sort of thing. Are you pooping okay? Or are you having any other medical concerns? And so all of this behavior modification stuff, sometimes there are things that we can do medicine-wise to help with sleep or medicine-wise to help with decreasing your fight or flight response, but we'll talk about those when we talk about the medication part. All right, so that is the first third of the plan. The second third of the plan is therapy. And so I am blessed to work with lots of different therapists. And so as a psychiatrist, the training program that I went through, they taught us 3 main types of therapy. Supportive psychotherapy, I think it may come up here, hang on, let me see. Yeah, I'll come back to this. Actually, I'll come back to the therapies that I do. The way that I describe therapy to a lot of my patients is therapy is really good at teaching you how to deal with stuff that you don't like, right? Their immediate idea is, do I have to sit on the couch and like talk about things? And I go, no, I mean, you can lay down if you want to, but the ideal goal is to help you cope, to help you deal with those things that irritate you. And it's different for each person. And so I always tell folks, a note about therapy is that dun, 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 you're a terrible therapist for yourself. So do not try to do therapy for yourself because it won't work, because you're so close to yourself that it's hard to be objective. It's hard to step outside yourself and go, yeah, that's kind of messed up. Why do I keep doing that? Why does every relationship that I'm in always end in flames? This doesn't make sense. And that is super hard to do, y'all. And so that's why it's very, very helpful to have somebody else go, hey, have you noticed that every relationship you're in ends up in flames? You go, wow, I didn't realize that, right? And so, yeah, so don't try to do therapy on yourself. If you like self-help books and those sorts of things, if you find them helpful, by all means do that. But just keep in mind that you may be missing. You may have a blind spot that you're actually not seeing. And that's where having a person is really important. And one of the things they taught us in therapy is in training is that friends can't be therapists, right? Therapy is something you pay for, you invest in, and they are not related to you. And that's what separates us from just casual advice, okay? And the dynamics are different. The relationship is different. And so, yeah, so don't try to do your own therapy. Instead, go and find a therapist. And that's where D2 comes in. And it feels like I know lots and lots of therapists. So if you need something, of course, I'm always willing to help where I can. So I was talking with a therapist, and she said that there were over 100 different types of therapy, over 100, so many that I can't keep up with. I only do 3 because that's all I'm trained to do. I didn't even know how to do systems work. The 3 that I do are CBT, so the thinkings, feelings, actions triad, and the key is to try to break that cycle between your thoughts, your feelings, and your actions. Supportive psychotherapy, which is all about validating that person's experience, making sure that they don't feel like they're crazy, because crazy doesn't exist, y'all. It doesn't, and that's one of my pet peeves when I hear that I'm crazy, and I'm like, you're not crazy. That's you have something going on just like all the rest of us. And then psychodynamic. So that's my favorite. Psychodynamic meaning, dynamic meaning the relation between 2 things. So past events, present events, or between people. And so that's my jam. I love to do it. I don't get to do it very much. And then basic behavioral therapy. So lots of, if you do this, then this happens. Because again, I see a ton of kids who throw fits and that sort of thing. And so, but yes, there's EMDR, which I think is magic, and I don't understand how it works, but it seems to. There's solution focus, which I went through myself, and I found it to be super hard for me as a patient going through solution focus, because you can't go backwards, and I always want to tie it back. I'm like, well, this is how I was raised, and my therapist is like, yeah, so what about now and going forward? I'm like, this doesn't work with me. So yes, and solution focused, insight oriented. I mean, so many accelerated resolution therapy, acceptance commitment therapy, lots of different therapies. The key is for if you're not a clinician on this particular webinar, is to ask the therapist. So find any therapist and ask a therapist, and they can generally walk you through what they do or who does what, so that it's not so confusing. And so I don't expect people to know their therapies, and that's the other thing, and be careful of what you read on the internet. And so keeping in mind the 2 big areas. So we talked about behavior modification and all that stuff. And then when it comes to therapy, just know that it's all about finding ways to cope with things. And that is super hard all by itself. So those are kind of the 2 buckets that we're working with so far. And we haven't even talked about the medicine. So that's how important these 2 areas are. And for my super analytical folks, I always tell them, like my analytics, so like my engineers that work at all these big companies, all the, the local companies, who I'm not going to name because I don't want to get anybody in trouble, but they're, especially guys, they're very, analytical. And I say, all right, let's be analytical for a second. Behavior modification is 33% of your plan. Therapy is the other 33% of your plan. 33 and 33 is what? 66. So 66% of your plan has nothing to do with the medicines that we're going to discuss. So if you want to get better, you want to get above that 50%, you have to do these other things. If you don't do these other things, I'm just spitting in the wind. We're not going to make any progress. And generally, especially for guys, that tends to make it concrete enough where they go, oh, you mean I actually have to do more work than just taking this pill? Absolutely, because there's more than just a pill for this. Okay. Now, we're to the pill portion. Hooray! So let's walk through this. So medications, my general mantra of my practice, and anytime I'm teaching medical students or anytime I'm teaching my patients, is we want to use the lowest effective dose for the shortest amount of time. Okay, so that's my caveat. So every time I walk into any type of patient appointment, that's what I'm thinking. How do I get this person to feel better with the lowest effective dose for the shortest amount of time? I always think, how do I get you off of a medicine? Now, there are some folks who have to stay on their medicine for years, and that's totally fine. But I'm still going to do my due diligence to make sure that I'm thinking, how do I get you off this medicine? Can I get you off this medicine before I even start it? If you come to me on a medicine, and for generally most psychiatrists, if you come on a medicine, we're going to see what we can do to try to get you off of that safely. And if we cannot, then we want to make sure that we manage as many of the side effects as humanly possible. And so medications, I jump into this. There are no happy pills, because if there was, I'd give it to you. And then there's no medicine for behavior. So if you think back to what we just talked about, right? So I don't have a medicine to make you eat right and exercise. I don't have a medicine to get you to get all of the goodness out of therapy that you need to get. You got to do those things separately. And so that's why it's super, super important. You keep in mind, there are no medicines for behavior. Those are choices that you can make. And then there are no happy pills. Now, it's I do some slight magic with my words there. So I have medicines that decrease depression, but they don't make you happy, right? And so that's kind of how I word it. Because some people go, oh my God, I feel so happy that I'm on my medicine. I go, great, that's you. You're doing that. I'm not doing that with my medicine. You are finding happiness somewhere in your life and bringing joy to your existence. And so in general, the medicine families, I'm going to give you all a super high level, and then we can talk specifics, especially during the question and answer period. In general, there are 3 neurochemicals that we work with. The first being serotonin, the second being norepinephrine, and the last one being dopamine. There are other things I'm going to walk through that aren't in these 3 fields, but the first thing I'm going to tell you is that each of these neurochemicals are created from the proteins that you eat. So let me flip it on its head. You cannot consume these neurochemicals and expect them to work. So if you took a tablet of serotonin, your stomach acids would destroy it. If you took a capsule full of norepinephrine, your stomach acids will destroy it. If you took a capsule of dopamine, your stomach acids are going to destroy it. So you can't get these things from outside. Instead, you eat the protein, and then as the proteins are denatured in your stomach, they go into your other small intestine, and then they get converted into these things. And so I always like to bring that up because you'll see lots of supplements and all sorts of stuff on the internet and on TV, and they're like, oh, just take this and you'll feel better. And I'm like, it doesn't work that way. Eat a balanced meal, go out and enjoy yourself with your family or with your friends, go for a walk. All of those things are super, super helpful at helping you make these particular chemicals. And then the next part is all of the medicines that most psychiatrists use just push these things around. So in other words, my medicines don't make you make more of these things. It pushes them around in certain parts of your brain so that they're more available for certain brain cells to pick up or to block it from other brain cells. And so that's why when I harp on diet as the first important thing, that's why I say, please do that. Now, is there a pill for this? So serotonin is kind of your anxiety. It's for anxiety, it's for mood. And when I say anxiety, that includes any of your kind of generalized anxiety. That means your anxiety kind of not specified, kind of like something's going on, but we're not really sure, all the way over to like your OCD, which is a crippling type of anxiety where you have a very difficult time breaking different cycles. And so serotonin is super, super helpful for all of those diagnoses, all of those conditions on the anxiety spectrum. Serotonin is also related to depression. And so it helps, again, block certain brain cells can pick it up a lot easier, and over time your depression will come down. Medicine names, just so that y'all are familiar, because I'm sure y'all have heard some. Serotonin medicines, the probably most popular is Prozac, which is fluoxetine. It's been around since the 80s or 90s. And then maybe even earlier, 80s or 90s, and then Zoloft is probably the second most common, which is sertraline. And then there's lots of offshoots after that, Lexapro and Trintellix and Celexa and those sorts of things. And those are all serotonin-based medicines. Very, very safe. The most common side effect from any serotonin-based medicine like those is upset stomach. Because remember, there are just as many serotonin receptors in your gut as there are in your brain. And so when you first start taking a serotonin medicine to start jacking with stuff, there's always a risk that you're going to have upset stomach. And so most times you can kind of just work through that, make sure you're eating your fiber, make sure you're eating right and all that stuff. And that side effect should go away. But that is kind of the most common complaint that I hear. When it comes to norepinephrine, so norepinephrine, a different type of brain chemical. Most times it's related to mood, it's related to anxiety, it's related to attention, and it's related to depression. One of the hiccups with that, let me talk medicines and then I'll talk kind of side effects and stuff. Medicines in the norepinephrine world are things like Strattera, which is for ADHD, if you've ever heard of that one. Elavil, which is amitriptyline. So that's an older medicine that we used to use before we had all these fancy serotonin medicines. Pamelor, which I think is nortriptyline. I don't have to write for these very often. That's why I don't keep them top of mind. But I have a handy dandy book of drugs that I can always pull up on my phone if I ever forget. Effexor, if you've ever heard of Effexor, that's venlafaxine. So that's a norepinephrine blocker. And then Pristiq, which is desvenlafaxine. So all of those medicines, super safe. Some of the hiccups with those particular medicines is because they work on norepinephrine, and norepinephrine is also related to your autonomic nervous system. Sometimes you can get elevated heart rate or kind of not hot flashes, but you get flushing, sweaty palms, that sort of thing. Again, very helpful medicines, and your psychiatrist or whoever's writing for your medicines will walk you through all the different side effects of those things, but they're generally very safe. And then that last group, dopamine. So dopamine is a brain chemical that is related to how your nerves communicate with your muscles. And so there are some times that if y'all have ever heard of Parkinson's disease, that's a disease where you don't make enough dopamine. And so as a result, you kind of get these short circuiting of your nerves to your muscles. And so if I use a medicine that blocks dopamine, sometimes I can, in a sense, make someone look like they have Parkinson's. Not that I'm trying to do that, it's just one of the side effects of those medicines. So if you block dopamine, dopamine is related to mood, it's related to agitation, it's related to aggression. And so a dopamine blocking medicine would be something like Abilify, if you've ever heard of Abilify, or Risperdal. If you've heard of Haldol, Thorazine, Stelazine, all of those medicines block dopamine to the point where I can literally kind of just lay out flat if I needed to. Not that I'm trying to do that. That's generally only reserved in the case of danger to self or others. But that's what happens with dopamine. So if you block dopamine, it decreases agitation, it decreases aggression. But sometimes you want to actually turn dopamine up, and that's what Wellbutrin does. So if you've ever heard of Wellbutrin or bupropion, it makes dopamine more available so that you can pay more attention and your mood is better. Your stimulants, so like Adderall and Ritalin, they push dopamine out so that it's more available so that you can pay attention for a certain amount of time, and then you metabolize it, and then you go back to not paying attention. And so depending on what you're trying to do, so if you want to push dopamine or you want to stop dopamine, number one, you have to have dopamine available for use. So make sure you're eating a good diet. And then whoever your person is, again, your prescribing person should be able to walk you through, hey, this is what we're going to do with this medicine to help you pay attention here or to help you with the mood there. And then if you're having hallucinations, because that's a dopamine issue. So anytime you're seeing things, we hypothesize it's related to dopamine. I can stop your hallucinations generally if they're dopamine related by putting you on a dopamine blocker. Caveat with that is stress can also cause hallucinations. So if you happen to be under a lot of stress and you're seeing things, it may or may not respond to a dopamine medicine. So that's an asterisk caveat. Y'all don't need to worry about all that. Talk to somebody who does this stuff all the time, right? So, and so those are your medicines. So is there a pill for this? Ish. If you need something for anxiety or depression, if you're seeing things or hearing things, if you're agitated and moody, if you're not sleeping, well, actually, that's a different one. I'll talk about that in a second. Yes, there are medicines that can be very, very helpful for each of those areas, but you cannot neglect all the non-medicine stuff. You cannot neglect your sleep, diet, therapy, and that sort of thing. I didn't put this up here, but in general, there's a different receptor in your brain called histamine, which y'all have heard of. Like you take Benadryl, and that's an antihistamine, which makes you really sleepy. So a lot of medicines in our pockets will use that receptor to help you fall asleep. And then there's another receptor called the Benzodiazepine receptor. So if you've ever heard of Xanax or Klonopin or Ativan, Valium, they hit a different receptor, and that receptor will literally calm you down. Benzodiazepines are the best and worst things ever. So they're best because they are really good at what they do. Like when I say they're really good at what they do, they do exactly what we expect them to do, which is calm you down. The problem is it creates what we call a psychological and physiological dependence. So psychological meaning you will start to feel like if you don't have them, you need them and that you can't function without them. And then physiological dependence meaning if I take it away from you, you literally go through withdrawals. You get shaky, you can have a seizure, you can do all sorts of stuff. And so that's why those medicines are very tricky. If I'm going to ever use them, I always teach folks that we're going to use them for a very specified amount of time. If I'm working with a person that's been on a benzodiazepine for a really long time, then I'll walk them through, this is how I practice, this is my goal for you. I want to get you on the lowest effective dose. If I can get you off, I will try. If I can't get you off of that, then let me do all of the kind of touching base again and again and again and again and again, so that you know all the side effects and that sort of thing. And generally, I can get most of my folks off of that particular thing, but sometimes that's not possible, just depending on the circumstance. Yeah, so those are all the kind of big medicine discussions and medicine options. In the past, we had lots of different options for medicine because in like 90s and 2000s, there was a lot of money in medicines. And so all the drug reps were coming around, farm reps, and I mean, it was like a new something every single day. Now there's not as much money in the pipeline. There's not as much interest in the pipeline. And so there aren't as many new drugs coming on the market as there used to be, which is unfortunate. And again, it's kind of a double-edged sword, honestly. Because it feels like now we have a good slew of medicines that we can use. In the event that nothing works, there's a whole other growing body of treatments that I didn't include in this because they're not pills, but there's ECT, which is electroconvulsive therapy. And it looks a lot more scary than it is. So actually I trained in it. And it's very controlled. But the idea behind that is that, for lack of a better term, if you push out all of the neurotransmitters at once, it allows things to settle and kind of, I wouldn't say reset, like they literally told us don't use that term, but that's the best term that I can use is all of your, when you induce a seizure, medically induced seizure, all of the neurotransmitters. So all your dopamine, all your serotonin, everything is pushed out at once, and then it kind of settles, and then we see how things go. And if we need to do a medicine or not, that's kind of how ECT works. TMS is transmagnetic stimulation. I don't really understand how it works. It seems to work for some people where you use magnetic coils over certain parts of your brain. And then there's a whole other new slew of information coming out with psychedelics. So ketamine and psilocybin and MDMA, and I'm missing one. I can't remember the last one, like mushrooms and stuff like that. And so those are going to be coming as options in the future as well. Let me go here. And so to kind of reorient us again to our discussion, so behavior modification, all of those things that do what you're, in a sense, you're doing what you're good at, doing those, being very mindful of the things that that you like that are helpful, and then you're being very mindful of the things that are not helpful. Then you do therapy. So therapy is all about finding coping skills to deal with all the stuff that's going on. And then when it comes to medicines, just know that there is an absolute slew of medicines, probably a good 50 total. Different options. Some are older, some are newer, that work in at least 3 to 5 different areas: serotonin, dopamine, norepinephrine. We can use a benzodiazepine, and then the antihistamines if we need to. It's very rare, and I'm a psychiatrist that does mostly kind of the mental health side, whereas in the substance use world, so even though it's that line is arbitrary, we just made that up between psychiatrists and therapists and that sort of thing, because there's overlap. But in the substance use treatment world, there are very specific things that you can do to help someone be successful with shots and blockers and all sorts of stuff. I don't really get into those things because it's hard enough to keep up with all of this knowledge over here. And I'm a big believer in do what you're good at, don't do what you're not good at. And so I focus on my stuff just because that's overwhelming enough. But those particular medicines, I'm intentionally leaving out of our discussion today, but if you have questions, I can always answer those. And so the takeaway from today is be comprehensive in your mental health approach, okay? Be comprehensive. If you go to one of the hiccups with the insurance-based model, which is why I don't take insurance, is that they lock you into a very fast appointment. So you fill out a survey or a form, you hand it to whoever, your doctor or whoever reads it really quickly. They say, oh, your depression is better. Let's go down on your medicine, and you're in and out in like, 5 to 10 minutes. And that part drives me bananas. Most of those doctors are very well meaning, because I know quite a few of them, but they're in an insurance-based system. The only way to pay your bills is you have to see as many people as fast as you can to get the partial reimbursements from the insurance company. And so as a result, it kind of skews things. Whereas for me, I'm like, you just pay me directly and we'll sit and I'm going to give you my undivided attention for the time that you're sitting in front of me. Yeah, it's totally, I love my job. I have the best job ever. And so that's why I go and I take all the time to talk about that comprehensive approach, and everybody leaves with that plan. These two things up here, Mindful is my private practice, so plug for that. We're over in Fort Worth. There's 3 child psychiatrists and 1 adult psychiatrist. And they all practice pretty similarly to me. And so that's where you can learn about us. And then Simply Psych. So I learned that I had no idea what I was doing in business. No idea. So I just kind of was making it up as I go along. And I was like, that's not sustainable. And so I got some coaches and sat down and had a come to Jesus meeting with myself to basically say, I don't know what I'm doing. I got lots of folks to help me. And so I built some strategies so that if other therapists are like, hey, I want to start a private practice, or I want to join your practice or whatever, that's what that company is. And so that's for all of you therapists out there who say, you know what, I want to break out of that insurance model and go out on my own. Then we have some support and things that we can use to help there. Now, with all of that, that's the big picture, but I would love to answer some of y'all's or all of y'all's questions. So thank you so much for your time and attention.
Innovation.
Oh, thanks.
Yes. So when you talk about there's not money in the pipeline for meds, are you talking about research?
Yeah, so that's a great question. So the question is when I mentioned there's not money in the pipeline, does that include research? I think research is ongoing. And this is completely opinion at this point. Okay, so there is a really big push to treat opiate addiction, to treat addiction, period. And so quite a bit of the money, so there's the NIMH, National Institutes of Mental Health, and then there's like SAMHSA, the Substance Abuse Mental Health Associations. And when you look at those streams, quite a bit of that money is going towards the substance use part, and not as much into the mental health part. And that's unfortunate because, again, there's so much overlap. Because health insurance companies don't like to pay for things, it puts a damper on any of the new drugs that are coming out. And so I think in the last couple of years, if y'all have ever heard of like Vraylar, that's a new one that's come out, but generally there are not as many medicines in the last 5 years as there were about 15 to 20 years ago.
Yeah, I know about that.
Yeah, and it's a money thing. I mean, one of the reasons why I like to do this, and I'm constantly talking about healthcare finance, is we need to shift. So our healthcare system is a procedure-based system. Most folks don't realize this, but when you look at neurosurgeons and they make $700,000 a year, right? Or you look at cardiology and they make what they make, and they're all smart doctors. I'm not saying that they're not, but they use a thing called a CPT code. It's a code with the government, and they can get a certain amount of money for each of those codes. Well, those are all procedure-based codes. Well, all I do is talk. I don't have any procedures that I do. So as a result, I don't make the money that they do using those same codes. And so we're all humans, y'all. And if you can make $5 from waving your hand, or you can make $10 from waving your hand, which one are you going to do? Or waving 2 hands, you can wave 2 hands, right? And so that's what has happened over the last 40 years is the medical system has skewed towards procedures, which is where, hey, yeah, I'll give you a hip replacement. I'll do all these things instead of, hey, let me pay you before you ever need a hip replacement to get up and move around or do Pilates or go to PT or OT or all those things. So the incentives in our system are perverse. They're skewed, and it's not y'all's fault. That's how the system was set up. So now what we have to do is go back and change the system, but you know how hard that's going. So yeah. Wah, wah, wah.
Yeah.
But yet we persist. We will make it happen. Yes.
Can you get a little bit more specific about medications for OCD?
Yeah. Yeah. So
Can I interrupt just a second
Sure.
and just tell the folks online that if you have a question, you can either enter it in the chat or just say you have a question, and then you can Kerrigan will let us know, and you can get off your mute and ask it. So either way, so sorry to interrupt you.
perfect. Yeah, so medicines for OCD. So the traditional strategy and the traditional belief is that it is related to serotonin, right? And so, and the idea is you start with the first dose, and then you really aggressively push the dose up to basically the highest that it can go. And so, and there's certain 3 or 4 medicines that we traditionally use. Now, if for some reason that's not working, you can do lots of kind of off-label things to try to help. So the idea with OCD is that your autonomic nervous system is in overdrive. So your fight or flight nervous system that keeps you alive is that it is just constantly on and kicking. And there are other medicines that you can use to actually bring that system down that aren't serotonin medicines. And so the key is working with that person and doing a lot of teaching and informed consent. Because you may start essentially a blood pressure medicine. Hey, I'm going to use that to bring your idle down. And hopefully with your idle down, your serotonin medicines will work even better.
When you say 3 or 4, are you talking about SSRIs, Prozac?
Yeah, correct. So
Okay.
the standard
Right.
medicine for OCD is fluvoxamine. I didn't talk about it because we literally almost only use it for OCD. So fluvoxamine, 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 whereas Prozac is fluoxetine.
Right.
Yeah.
Yeah.
And
So
so
what is that? Zoloft?
fluvoxamine is Luvox, if you've ever heard of that one.
That's kind of an older one.
Oh,
Yeah.
Mhm. And that's the other thing we're learning is that a lot of
Yeah.
our older medicines that we
Oh.
exchange for the newer medicines are actually are working better. And so, yeah, and then fluoxetine, which is Prozac, sertraline, which is Zoloft, and then Paxil, which is
Yeah.
paroxetine. And that one's making a comeback. It fell out of favor for a while because it has a really short half-life. So, which is a fancy science word for it metabolizes really fast. And so because it metabolizes so fast, some folks can have a withdrawal from it. They'll feel like they have a flu, they get like achy and they don't feel very good. And so, but it's a great medicine for anxiety, and depending on your situation, sometimes it can help with OCD.
Do you do telemedicine?
I do. It is not my favorite.
I understand.
Yeah. So I'm one of those folks. I was taught the old-fashioned way as soon as you walk in the room, I read everything and take in all the senses, and you sit down and how you interact and everything. And so telemedicine keeps me from seeing all of those cues. But I mean, I have seen some people just flourish with telemedicine. I don't know if it's the time not having to be in traffic. I don't know what it is, but like I have quite a few folks who say, can I stay telemedicine because I think it works and I'm feeling great. And so, yeah, I oblige even though I'm crotchety and like, no, yeah.
Thank you.
Oh,
What do you think of the enzyme testing to narrow down?
Yeah, this is a hot button, y'all. So this is again, let me give the disclaimer of yes, absolutely talk to your person. I'm going to give you my opinion. So all of those enzyme testings don't test for efficacy. They test for basically tolerance. Like, do you metabolize it fast? Do you metabolize it slow? Or somewhere in the middle? But they don't actually tell you if it's helpful. And so that's the issue. So And it's very sleight of hand. So a lot of the testing places will send you back this beautiful graph, and there's red for, oh my gosh, that's bad. And then there's yellow for have some caution. And then there's green for, by all means, go for it. And I've seen probably an even split of a person coming to me and they're super stable on whatever they're on. And they say, hey, can I get that testing? And I go, no, I don't. I mean, you can if you want to. It ain't no skin off my teeth. It's all if you want to pay for it or not. And we do the testing, and it turns out that the medicine that they're stable on is in the red category, right? And they're not having a problem. And so what do you do with that? Do you take them off the medicine because it's in the red category?
It's what medicine is working.
Correct. And then vice versa. I've seen it the opposite way, where sometimes it has been helpful. We've tried different streams of medicines, and we tried medicine that they metabolize a lot easier. And oh, that works. So, but yes, it only tells us how well you metabolize, not if it's actually effective.
And there's no correlation?
I'm going to say no. And that's why the clinical use is still not indicated. So if we order the test, it's more kind of just for informational purposes only. And most of them will have that little disclaimer on there. They'll literally say, you know, this is to add to the clinical discussion, not to make a definitive clinical decision.
So what does it add if it's not efficacy?
Yeah, so
Dose?
yeah, I would say it adds just understanding of how metabolism works, honestly. Yeah.
And that won't impact dosage?
It could. So yeah, so like if you see something in the red and I say, okay, that's our only option, you know, fluvoxamine or whatever, that's our only option. It says it's in the red, we'll go slow. So instead of doing the standard dose, we'll do half, right? And then we'll work your way up. So it can inform, but it doesn't decide. That's what. And actually, one of those companies got in trouble because some of their literature was saying that you can use it to make decisions. And I don't know if it was Genomind or I can't remember, but they got in big trouble for it. And that's why it was one of the two big ones, and they kind of disappeared. And now there's like one or two. The other hiccup is the cost, y'all. So it used to be insurance that didn't cover it, and it was like $5,000 to do this stuff. Oh yeah, and one of my patients got a bill for $5,000, and I was like, no. But a lot more people are covering it now. So
Well, why?
Insurances. They just decide what they want to cover and don't.
Because it's not effective.
Correct. Yeah, some of them say, well, it's not clinically indicated, and you're just doing it for your own edification, but you know, so we'll charge.
We're getting kickbacks because we own part of the.
I didn't know doctors got kickbacks for medicine prescriptions. I heard that at a doctor's office, and I went to my pharmacist, like, do my doctors get kickbacks for my meds? They said, yeah. So I was like, I mean, I just didn't know.
Yeah.
I still love my doctors, and I fill the prescriptions, I just never take them, you know?
Yeah, that would be unusual. So, and I'll put it to you this way. So, because kickbacks, if you own a pharmacy, yes. So, I mean, there are ways that you can own micro pharmacies. I don't know if y'all know this, but you can literally spend a little bit of money and they'll come and put a pharmacy like in your building. And then if you own that area, then you can refer to that pharmacy, and I can see where that could happen. You're not supposed to do that, but I can see where that can happen. But the actual medicines itself, that should be really rare that a doctor gets any payment from that.
Further investigation, but
Yeah.
that's what my investigation revealed was, oh yeah, they get it. It's, you know.
Well, they'd lose their license.
Yeah, because that would be super unusual. Mhm. Yeah, because the other part is the infrastructure of making medicine is so it's so foreign to us. There's a big push. So one of the reasons, do y'all remember that Martin Shkreli guy? He took that medicine and he said he was the only one, they were the only one making it. And so he jacked up the price from like 30 cents to $750. Yeah, there's a big push now to have more, it's called like the Safe Harbor Act, but I can't remember, but it allows people to make generic medicine so that then we can bring the cost down. But even then, I don't know that doctors can own those things. I mean, I guess they could. I don't know. It seems like a lot of liability.
Basketball team owners can.
Oh yeah, I got it. Good old Marky Mark. Yes, indeed. So yeah.
Does anybody?
Yeah.
No question.
Okay, on the enzyme testing, does that include, and I'm forgetting the name of, it makes me think of iron, but it begins with an F, and it's if you're low in that can affect depression.
Folic acid.
and folic acid.
Yes.
Is that on there?
It
Or
is.
Okay.
And I'm trying to remember, this is where I'm totally blanking. Because folic acid, there's a different name for it, and I can't remember what it is. But yes,
It's a vitamin B or something.
yeah. And I'm blanking.
Yeah.
Yeah.
I know, it gets confusing.
It does. Oh my gosh, it's not DMN. Oh my gosh, it'll come to me. And
But that is true, if it's low.
correct. So, so vitamin D, folic acid, whose name again, I'm completely blanking on. If you see that if you get just regular lab work, you don't even have to get enzyme testing. You just get regular lab work, and you see that that's low. It's helpful to get folic acid supplementation. And the name of that escapes me as well. It starts with a D.
And is there good research now? I know it was kind of up in the air about the vitamin D and what levels, how low is related to depression, how high do you want it? Do we know that yet?
That's a great question. I know that it is a thing, but I don't know what the levels are. Because I've talked to quite a few psychiatrists who will always get a vitamin D level, and then they will then supplement if it's low. And I can't remember the name of that medicine, but or that it's like a medical food. So it's not a traditional medicine. It is so a medical food is a way to get higher levels than you can buy off the shelf. So like if you just go buy vitamin D off the shelf, that's a supplement. But if you want kind of medical grade, like high potency, they consider it a medical food, and you need a prescription for it. And so, yes, that can be helpful, but I'm not sure what the literature says about that part. I don't traditionally do it, and I think it probably is like 50-50. Some psychiatrists are like, well, why spend $100 on that particular supplement when you can just get it, not supplement, that particular medical food when you can get it as a supplement, and then change your diet. So, but I don't think it hurts. It doesn't hurt to make sure that your vitamin D levels are where they're supposed to be.
Is there any negative for long-term opioid usage other than addiction?
Yeah.
If you're not addicted, and are there other long-term bad effects?
Good question. So I'm going to say it depends. So anytime you talk to a psychiatrist or a counselor or a therapist about anything, and they answer a question, it'll always have some version of it depends. So if you don't have any abuse potential with that medicine, then yes, you can use those medications a longer term very, very safely for chronic pain and other things. So, but we try not to. But yeah, they should be very safe. Now, if you do have an abuse potential, or if there's something going on, like if you get a sense of euphoria from it, you're feeling good above and beyond just treating your pain, that's where it can be problematic, because then you're slipping into that dependence role.
Yeah, that's the pill you can take for happiness that you said doesn't exist.
Correct. Yeah, theoretically, that is correct.
The other thing I heard with a co-counselor went to a workshop, and she said long-term use of ADHD meds can suppress your natural happiness receptors in your brain. Have you heard anything about that?
I haven't heard it put that way.
And I may not be putting it correctly, but basically it makes you less, your own natural happiness can decrease with long-term use of.
Yeah, so that one would be, I think, super controversial. And the reason why I say that is I think it just depends on the person. So for example, I've worked with especially women between the ages of like 25 to 45, that when they get on their stimulant medicine, ADHD medicine for the first time, their happiness goes through the roof, because they're like, oh my gosh, I didn't know I had ADHD. Now I feel like I can get things done. I don't feel so bad about myself, so on and so forth. And so their lives are actually better. Could it be that if you're on ADHD meds for 20 years, that it could mess with your happiness? I mean, it's not supposed to do that. ADHD medicines work only the day that you take them. Let me rephrase that. Stimulant medicines work only the day that you take them, to give you a burst of dopamine, and then it's supposed to metabolize. And so it should disappear the same day. There shouldn't really be an additive effect over time, one way or another, because they designed them that way. But I've been wrong before, but that's not something I've seen.
That's good.
Yeah.
So the SNRIs are the combination. Is that right?
Yeah.
Is that the serotonin and norepinephrine?
Most of them do, correct. So they'll do a little bit of serotonin and mostly norepinephrine.
Ah,
Mhm.
okay.
And so, and they can be, again, everything has its own double-edged sword. So you have to just be very mindful of what else is going on for that person.
Yeah. So my, what I didn't hear you say that I wanted to hear was just the serotonin, when you're looking at symptoms and you decide serotonin versus norepinephrine. I heard you say anxiety for both, depression for both. So can you talk a bit about how you do a differential diagnosis for that?
Yeah, so differential means basically different. So you have every therapist, every doctor will, whenever you first come into the room, they're going to start guessing as to what's going on. And then the goal is you rule things in, so you make it more likely, okay, I think this is what's going on, or you make it less likely, like, no, that's not going on. And so we use the book called the Diagnostic and Statistical Manual, so DSM, to rule things, to categorize everything, and then say, is it more likely this or less likely this? So the key is you have to come to some conclusion. So because if you don't pick something, then you're kind of just throwing medicines willy-nilly, and you don't want to do it that way. And so what I do is I get all the history, get all the information. I try to come up with the maybe top 3 things that I think is going on. And then those top 3 things are generally linked to a type or a category of medicine. So if you come in and I say, oh, you know what, I think you have autism, and that's and part of the autism spectrum for quite a few folks is an anxiety component. They tend to worry a lot. Now, is it separate worry? Is it its own line for anxiety and I need to treat it as that? Or is it more related to autism and I need to treat you in a different way? Well, those help determine, the label helps determine which medicine, which category I go into. And so that's why there's some overlap. Sometimes they'll say, oh yeah, that's an anxiety issue, we're gonna go serotonin. Or I'll say, that's a depression issue, let's actually go norepinephrine. Or it's a depression issue, let's go with dopamine. So that's kind of how those happen. And then I just take into account the side effect profile and then what they've been on before, whatever the person has been through before.
So how do you say dopamine, norepinephrine? I mean, depression, norepinephrine, depression, dopamine.
Yeah, it all depends. So because both of those are related to depression.
Right. So how do you decide that? Like what kinds of things are you looking for?
You mean for treatment or for naming it depression?
Treatment.
Yeah, so it's what you've been on before, what you tolerate, family history. If you came with one of those gene things, we could talk about that. It just depends. So like if you've never been on anything at all, the least noxious thing is a serotonin medicine, right? So then that's where I would start. But if you've been on like Prozac and you're like, I hated it and made me feel horrible, or my mom took it and she felt horrible, then I go, okay, well, let's maybe move somewhere else.
I just wanted to go back because I'm really interested in this particular subject because I've always been interested in vitamins. And, I've been doing some studies about which ones are working, but, like D3, B12, another one or two. But they always put it out there, but they don't really ever give you anything to go on whether it's working or not. They're doing this. How do you use that kind of information? I mean, just like what we did just in here was we talked about it, but then there wasn't any conclusion about it.
Yeah, so one of the hard things that each doctor has to learn and each therapist has to learn, everybody has to learn, is that we are educated guessers, right? And after you've seen something enough times, you tend to guess more correctly. But there are going to be times where you're just wrong. Somebody will come in and they will look like they meet every criteria and you're going to start these medicines and it just doesn't work. And so, I go into each session thinking, okay, that may happen. And then if it doesn't happen, great, right? I guess correctly. But I'm always looking for other things. And same thing. So in the world of like vitamins and understanding how vitamins and minerals affect mental health, the research is just not very good. And so we're kind of, our educated guessing just gets worse. It's not, sometimes you may as well just, throw something at the wall and see if it sticks. But there is a new, not new, but there's a push called integrative medicine. So one of the doctors that works in my practice, she uses micronutrients, which are kind of very refined supplements that have been tested in randomized controlled trials and all that kind of stuff. And she uses those to help improve mental health outcomes. I'm not trained in that, so I would just be guessing as to what she's doing and how she does it with like magnesium and all these different things. And so I think that body is expanding and becoming more nuanced. And in the meantime, we just kind of, make it up as we go
You
along.
call it integrative medicine?
Integrative medicine. And then micronutrients is, she trained at the University of Arizona because they have a fellowship in, and
Functional medicine is also.
same thing. Very similar. And so, so all of these things are changing and growing, which is exciting. So even though we may not have new medicines coming down the pike that's going to cost us gajillions of dollars, we have these other lines of interesting things happening. And the key, in my opinion, is always get the right person in front of the right clinician, right? Some people don't need to see a psychiatrist at all. And that was one of the hiccups when I was working in a big system, is a person would wait 6 months and come to me. And I'm like, oh my God, you just need therapy. That's all I don't need to put you on any medicines, but that person sat and waited for 6 months, and then vice versa. There are people who have been stuck in therapy for years and years and years and years. I'm like, yeah, you do need a medicine. We can treat that, right? So I think we as a mental health world do a really bad job of triaging people and getting them to where they need to go as fast as possible.
Yeah, she needs a good word for it.
Yeah.
So it's integrative like holistic medicine?
Yes, so lots of different names, and this is where, again, I'll probably get in trouble, so please don't send me emails, but holistic, functional, integrative, and each one has their thing. And I love them all. I say, if it works and it is not hurting you, do it, right?
Are you saying integrative or?
Integrative.
Integrative, okay.
Integrative, TIVE, integrative medicine, because integrated medicine is the idea that a therapist is in with a family care doc in the same clinic, right? Because that's the integrated care model, where you have a pediatrician and a child psychologist, and then the family systems therapist, and they work together, and that's the integrated care model. So lots of all these terms. Sure.
That's why they call it the practice, medicine and practice.
A little bit. What other questions?
I love this. Could you just start over at the beginning?
Let's do it again.
Yay! What's really funny, so, and I give this talk, or versions of this talk a lot, because we truly have to work together. I cannot stress that I cannot do my job without amazing therapists, right? I cannot, it's impossible, because not only are they in the field, they're bringing up new ideas and new, DBT grew out of CBT. So CBT is cognitive behavioral therapy. Well, Marsha Linehan, who's a therapist, I think she was based in Dallas, she took CBT and grew a different version that now is used in all sorts of different places, right? And so we need to continue to iterate and grow all of these things. And so I love the idea that we continue to work together to make that happen.
You're the first psychiatrist I've ever met, and I've dealt with many dozens of them over the course of my lifetime for my family. And that was not just strictly a pharmaceutical psychiatrist.
Yeah.
Thank you.
Oh, you're welcome. So yeah, that's it's my training. I trained at the University of Kentucky, where the staff was split literally 50-50 with old white-haired psychiatrists who literally they would put people in the hospital and they would work with them for 6 months to a year with no medicines and just do intensive therapy. And they were psychiatrists. They only had like Haldol and Stelazine and Thorazine, and that was basically it. So those guys and ladies were on staff, on faculty. And then we had the new agey kids who were, knew every receptor backwards and forwards. They knew all the research about and then they would have battles. I mean, it was like we would have a grand rounds and a big discussion, and it's, why didn't you just do this type of therapy? And the younger faculty would go, no, you need to do this. And we got to learn from that tension. And so, and now I get to bring it because yeah, most of my kids, I see lots of kids with ADHD, lots of kids with autism, lots of adults with autism or intellectual disabilities. And I get to do a lot of therapy rather than just drugging them up, right? And so, and it's fun for me. It's reassuring to parents. It keeps people really connected. So yeah, I appreciate the compliment. Thank you.
It's amazing. And one thing about ADHD and having it and working with students and their parents, with the drugs, you know, if you do take the medication while they're on the medication, focusing with the medication, then you can teach them behavioral strategies, you know, and you can teach them to learn their own systems. The only thing with ADHD, you know, you come up with that perfect thing that exactly works for that student, and the teacher's thrilled, the parents are thrilled, everybody loves me, and it lasts about a week to 10 days. You know, I just have to come up with a new system for myself every week. Yeah, sure.
Any questions online? No. Anybody online that would like to ask a question? Feel free to unmute.
I ask another question after you check that.
Yeah, sure.
I'm okay.
Okay.
Yeah, you're looking.
Yeah, go for it.
Okay, ADHD with hyperactivity. I've seen kids, when they ask you, just thinking of the brain, who, when they reach puberty, it goes away. What is that?
Yeah, so
It's like they're like on meth, and then all of a sudden they go into puberty and it's gone. And I've seen them go into adulthood and they're stable. They're
Yep.
not-
Nobody ever told me about this.
Yep, it is a
Maybe
thing.
I haven't gone through puberty.
So ADHD, so attention deficit hyperactivity disorder, ADHD, in the DSM-4, the fourth version of the book, they changed it from the third version. So the third version was ADD, so attention deficit disorder. So when they went from 3 to 4, they added the HD part, and then they made 2 subtypes, or technically 3 subtypes. The first subtype is inattentive type, where you don't pay attention, you have difficulty staying on task, you daydream, you give a kid a list of 3 things and they remember the first thing and the last thing, you can completely forget what you said in the middle. So that's the first type. Second type is the hyperactive impulsive type. And so that's where kids are constantly moving and blurting and touching and fidgeting and squirming and just all over the place. And then the third type is a combination of the first 2. So where you don't have, where you're having trouble paying attention and you're having trouble staying still. What I generally, yeah, pretty much. And what I generally say to most of my parents is if your kiddo has the hyperactive impulsive type, they're pretty much going to just outgrow that once puberty hits, because their frontal lobes start to develop. The frontal lobes are like the brakes on your car. And when you're little, and especially if you have ADHD, the hyperactive impulsive type, your brakes don't work very well. So your car just runs around and runs into stuff and it's just chaos all the time. Well, as you grow, you start to build that executive function. You start to slow yourself down. And so that's why you don't see very much hyperactive impulsive type in teenagers and adults.
Thank you. I told everybody that when they age and ADHD. I don't like it. They have age. I'm like,
Yeah.
and they
And
say,
so,
you have so much energy. And I'm like, what's referred to as hyperactive.
yeah.
Creativity.
In the eye.
Yeah,
of the
exactly.
beholder.
Yeah, and don't
Yes,
forget,
creative.
yeah, there's creativity, there's temperament, there's personality, there's will, there's drive, all these other things that make us who we are that will hopefully still continue, extroversion and introversion and all that stuff. So, but yeah, so in a sense, yes, kids will almost universally outgrow that part. The hyperactive impulsive part. The inattentive part can stick around depending on the child and the situation.
So 20 years of working in public education with kids and being an LPC and having it myself, I have never heard that it goes, the hyperactivity goes away. What happened to me? I don't get it. Well, it's puberty, I don't know.
Yeah.
Any other questions? No. Thank you, thank you, thank you.
You're welcome.
Wonderful.
Yeah.
Yes, exactly. Thank you so much.
Oh,
That was
that's
so
totally
informative, wonderful, and I feel like I've learned a whole bunch. So appreciate you coming.
No, it's my pleasure. Thank you.
We'll have you come back. Thank you all for coming. For CEUs, those of you online, email info@D2counseling and we'll get you your CEUs.
I thought down here. Oh, the ones online.
The ones online. And then next month, Kerrigan, who are we having?
Laney and Brian,
Yes, and the topic is?
the use of polygraphs and disclosures in therapy.
The use of polygraphs and disclosures in therapy. And this is going to be given by two incredible therapists in our community. One of them has just completed her third book in this area of problematic sexual behavior. So it'll be very informative, very useful. So I hope you'll be there. Thank you for coming.
Thank you so much for doing this.